Hi, my name is Jo Gibson, and I, until recently, was a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit. I now work as an upper limb rehabilitation specialist at Rehab for Performance. And as ever, I like to come on a Monday night and have a little bit of a chat about all things to do with shoulders. Generally, some things that I've seen in the clinic, some interesting patients, whatever I fancy talking about and sharing with you in an effort to share practice, the challenges that we all encounter on a day to day basis, but importantly, also some little tips and tricks if they're relevant along the way. Now, I'm sorry I'm here a little bit earlier this evening. I'd forgotten I was actually doing a webinar at 7 o'clock. So I didn't want to miss out because I'm away on holiday next week. So I was keen to get another one in before we go. Thanks to you, those of you who've sent lots of ideas for future discussions. We've had some great suggestions. So I need to do a bit of homework and get some suitable case studies, but I'll be back answering your questions as according to your request. So thank you so much for doing that because it makes it fun for me too. Now, tonight's is a little bit different. We've talked about some case studies, we've been talking about the challenges in clinical decision making, but this was actually a question that I was asked when I was teaching in terms of tools for particularly targeting proprioception. Now, the question I was asked was, do I use the FlexiBar or the Body Blade or the FlexiFoil, whatever you want to use it, in terms of training and improving proprioception? Now, this is a really topical question, so definitely stay tuned because there was a really lovely review by Amanda Agger published last year, which actually showed that when you looked at whether or not conservative rehabilitation could impact proprioception, then the bottom line was there was moderate evidence both for doing training on a BOSU or a wobble board and also the FlexiFoil. So moderate evidence to support its efficacy. But let's just have a look at a few things first of all, because one, yes, in terms of proprioception, we're talking about our awareness of positioning and movement in space. If you like, the interaction of our somatosensory system in response to our environment. And certainly people like Sir Charles Bell, way back in the 1800s, described it as our sixth sense. But proprioception is a really general term and it encompasses lots of different subgroups, if you like. So when we talk about proprioception, actually what we're considering is kinesthesia, our movement sense, joint position sense, or our orientation in space, which obviously has both active and passive domains, but also our sense of force and velocity. Now, of course, our proprioceptive receptors integrate with our visual system, our vestibular system, our sensory system, and our central nervous system to impact a motor response and impact all those kind of unconscious continual activation of our dynamic restraints for movement and motor control in response to joint loading and motion. So, if you like, it's always sampling what's going to happen next, basing it on previous experience and correcting those movement errors. Now, when we look at proprioception as a term and we look at those subgroups in patients with shoulder pain or pathology, so our instability cohorts as well, there is moderate evidence for impaired kinesthesia, so sense of movement in people with shoulder pain and in people with instability. There's very low evidence for any reduced sense of force, if you like, and velocity. But if we're honest, that's because not many people have actually researched it. And equally, there's conflicting evidence for changes in terms of active and passive joint position sense. So intuitively, you might think, well, if somebody's got pain or instability, then it must impact their joint position sense. Actually, that isn't necessarily well supported in the trials that are out there at the moment. Now, when you consider that our proprioceptors receptors interact with all those other fabulous sensory systems in terms of our touch, our vision, our vestibular system, our auditory system, then perhaps we're just very good at compensating and actually upregulating other parts of our sensory system. So we still really have a very good appreciation of where we are in space. So there's a lot about proprioception that's actually quite challenged within the literature. Now, as I say, in terms of this lovely paper by Agger et al., and I'll post a link to that, the bottom line is kinesthesia is the thing that has the biggest evidence base at the moment. So remember, that's our movement sense. However, we also have to be very conscious that in trying to measure it, this is not without its limitations. If we look at lots of measures that have looked at active and passive joint position sense, we find the differences between people with pathology and the differences in people who basically have no symptoms of or shoulder problems at all are tiny, like point something of a degree or 3 degrees at most. And we have to kind of really query what the clinical relevance of this is. And I guess the other question is it artificial, trying to make something something conscious that essentially is unconscious in terms of our everyday function. So when we try and separate sensory input and our neural networks and those psychological domains, it probably, you can see the flaws in terms of perhaps things we're trying to do, and arguably it could potentially be futile. Now, when we look at what is the most reliable way of looking both at threshold to detect movement, our kinesthesia, and also our joint position sense, there's no doubt that the isokinetic dynamometer comes out on top. Lots of clinicians have looked at things like angular error in terms of target matching, so things like our laser pointer. Now, laser pointers actually come out quite well, but not as reliable as the isokinetic dynamometer. When we look at things like inclinometers and apps on our iPhones that we can use in terms of joint positioning, again, they perhaps, that when we look at the intertester correlation coefficient, then perhaps they're not as good as we think. And certainly some lovely work, again, done by Amanda Agger, suggested that for tools to be useful clinically, they needed to score above a certain level. And the only thing that really did that was the laser pointer and the isokinetic dynamometer, and then potentially a test that Amanda's been developing in the background, but we don't have enough evidence to be able to use that clinically just yet. Now, again, if you think of what I've talked about in terms of integration of all those different senses, is, and that essentially this is all about our constant response and sampling with our environment, then arguably perhaps functional tests are better, or performance or task specific, in terms of perhaps they give us a better measure of how those things are coordinating together rather than trying to break them down. Now, certainly when you look at things like a pressure biofeedback and look at force matching sense, again, that has good reliability. We just don't have evidence about it specifically in our shoulder pain populations, as in how is it affected. We know that patients who've had long-term shoulder pain tend to overestimate the amount of force required to do an activity. So by its very definition, they're working harder and it's less efficient, a potential risk factor or something that might influence their recovery. But when we look at things like the ASH test, the athletic shoulder test that looks at the rate of force production, then things like that and the closed kinetic chain upper extremity stability test. So the ASH test is where essentially you're pushing down in prone in the Y, and T position as hard and fast as you can. It was originally done on force plates, but can be done with a handheld dynamometer or again on a pressure biofeedback. Again, correlates well with that kind of force production sense. If we look at closed kinetic chain upper extremity test, this has been purported to correlate well with those different aspects of proprioception. But I think we need to be a little bit honest that that link perhaps hasn't been demonstrated as clearly as we think. But again, it's a performance test where you just have your hands about a meter apart in the plank position or on your knees if you can't sustain the plank position, and how many touches you can do. So coordination, speed, and again, we have some nice normative data in terms of what we should be able to expect from different populations. But equally, if we look at those different aspects of proprioception, things like the shoulder endurance test, things like the amount of excursion when somebody does a drop and catch, the sorts of things that we might use with our instability patients, those as well as accuracy-based tests in terms of our laser pointer. So can we accurately trace a line? Or even that fabulous fairground game when you've got the thing where you've got to control and not touch the thing that goes buzz. Maybe these things actually have better value rather than breaking it down into some of those very nuanced aspects of proprioception that almost take away some of the factors that influence it. Now, when we look at our rehabilitation, all right, assessment's not without its challenges, but in terms of the question I was asked about the FlexiFoil, why might that have a potential role? And is it something that I might want to look at using in my practice? Well, essentially, if we look at what we're trying to target in terms of our proprioceptive receptors, if you like, within the system, what are we talking about? Well, I don't know about you, back to my college days, I'm sure you'll remember we have in our capsula ligamentous complex, our labrum and our skin, we have those Ruffini endings, which essentially are stimulated by tension, compression, rotation. They're our limit detectors. Then we have those Pacinian corpuscles, again in the capsula ligamentous complex, the labrum and the skin. And again, compression, tension, and the rate of loading seem to specifically impact those receptors. So you can see some common themes already in terms of compression, tension, and a range. But also interesting with the Pacini corpuscles, they seem to be particularly affected by vibration, which is one of the postulated functions of the FlexiBlade or the FlexiBar. Now, when we look at our other proprioceptive receptors, our Golgi tendon organ within the muscle and the capsular ligament complex. Again, tension is a key feature that impacts those. And of course, our muscle spindle, again, tension and rate of tensile loading. So you can see in terms of manipulating our exercises, we've already got lots of clues. And you could almost argue, when is an exercise not proprioceptive, particularly if it involves compression, particularly if it involves changing tension, which if we're doing any sort of muscle loading or strengthening, when itself has a good basis for improving proprioception, you can see some very simple things just increase the value of those exercises. Now, Amanda Agger did suggest within this conservative management review that there was a possibility and an emerging theme that perhaps there was a training effect with shoulder proprioception, and we should look at targeting the specific deficits that we see in different populations. So, for example, if you look at a population with instability, they seem to like tactile input to improve their performance on accuracy tasks. Similarly, if you look at athletes with shoulder pain, then there is some evidence, again, a tactile input or tape or giving them some external stimulus, again, seems to improve their accuracy. But we have to be honest, there's conflicting evidence about that. Now, similarly, in terms of improving proprioceptive, what's really key is that the most evidence we have is those that have a deficit, we do seem to be able to change it. But again, remember, we have to be a little bit honest in that we're basing this on tests that show tiny, tiny changes. So what about the FlexiFoil? What is the kind of premise? And as I say, remember that this compared well with something like just doing upper limb rehab on a wobble board. Well, you can imagine in terms of the reactive stabilization, when we're kind of doing this wobbling, if you like, of the FlexiBar through range, it ticks a lot of boxes in that potentially it's going to stimulate both the Ruffini endings and the Pacini corpuscles. It's going to impact our muscle receptors. And the bottom line is there's also probably going to be some mechanoreceptors. But what's key about all these aspects of proprioception is we're working that through range and end at range to actually maximize those effects. Now, there's no doubt the vibration characteristics of the FlexiBar has the potential to have a good proprioceptive impact. However, have we got any evidence to show its effect? Well, again, authors that purport its use also talk about something known as the tonic vibratory reflex, which is actually an involuntary muscle contraction resulting from a vibratory stimulus. It's alpha motor neuron excitation, and it can lead to acute and transient improvements in neuromuscular performance and actually, interestingly, increased EMG activity. We also know, and I'm sure you remember I've talked about vibration on the Facebook Lives before. We had that lovely paper from Grant et al. But we have an evidence base that shows that vibration can be a very effective way of activating the supplementary motor area, the dorsal premotor zone, the primary motor cortex, and the somatosensory cortex. And so, if you like, vibratory stimulus definitely has an impact in terms of affecting excitation of the central and peripheral structures, facilitating movement, improving accuracy, and if you like, decreasing variability of joint position sense in young, healthy adults. And that's the key. It's only been shown in young, healthy people. We don't have the same evidence base in those with pathology and how that might potentially affect that. Now, as I say, the other thing we have to be careful of is too much of a good thing can be negative in terms of if you do too much vibration for too long, actually it can induce muscle fatigue. So one of the key premises of the FlexiBar or the FlexiFoil is that vibration is one of its key mechanisms. But the other thing that's interesting is there's been some studies looking at comparing it with a similar weight of dumbbell and looking at stuff through range. And it would seem that that perturbation resistance does have some added effect in increasing the levels of activity in the muscle system. Now, I know EMG isn't without its flaws, but in terms of how the authors have reported their evidence, there definitely is an impact on changing the contribution not only of the local system, but also the rest of the kinetic chain. So again, all of you that have heard me talk know I'm a bit of an advocate of the kinetic chain and working the whole of the body. But again, using the FlexiBar in standing positions on one leg or whatever potentially increases the contribution of the rest of the body, increases the need to control those postural perturbations. And so again, we're targeting lots of different bits of that proprioceptive system. Now, if we look at the specific use of the FlexiBar in terms of the evidence, and yes, I did a lit search to look at this so I could give you what was out there at the moment. If we're honest, the studies that are out there are really small numbers. We have some looking at its comparison just with TheraBand in people with a rotator cuff repair, both groups did well, and it seemed to have a good effect on, if you like, achieving good balance of the scapular muscles. Again, let's be cautious, it was based on EMG. But equally, most of the evidence we have of effect is in a healthy population. At the moment, we don't have any evidence of effect of neuromuscular facilitation after flexible bar use in terms of patients with shoulder pain. There was one paper years ago looking at patients with instability that again reported a positive effect, but there was no control group and it didn't compare it to our other interventions. So I guess if we look at what it potentially goes, yes, it's a rehabilitation tool that adds some perturbation. It makes your muscles work hard. It seems to affect in a vibratory impact. And all those things could be a potential use in terms of targeting proprioception. But remember what I said, when is an exercise not proprioceptive? We can make it more proprioceptive and enhance its value by thinking about those things like compression, working at end range in terms of rotation as well as elevation. Rotation is a really great way of winding up those capsulogamentous structures, tension through that muscle system, an unstable surface, vibration through range, some very simple things that we can do. So the question was, do I use the FlexiBar in training? And the fact is, I do have one in the clinic, but interestingly, it was something I thought, oh, it's tucked behind a cupboard somewhere and I haven't used it very much. The other thing we have to be very honest about is the novelty factor of rehabilitation tools that patients perhaps haven't used before, a little bit like the Swiss ball, which is something I do use a lot in my practice. But why? Yes, it's colourful, so it ticks that visual system. For patients who've not used it before, it has a novelty factor. They relate it as being something different. And I think we have to be very honest in reflecting that the novelty value of tools, again, potentially will have a temporary impact on that sensory system. It's something different. So I guess in answer to the question, it's not something I use a lot. I've shared with you the evidence behind why it's purported to use. Is it superior to anything else? We don't have evidence to support that at the moment. But I think what was actually really interesting when I started to look at this and when I looked at the evidence that's out there and our current understanding of proprioception, it's something that we think about a lot, and yet the evidence base for deficits is actually relatively limited, and most of them relate to that kinesthesia, but we're seeing this emerging theme in terms of force production sense. So not about active and passive joint position sense, but more those dynamic qualities. So again, it seemed to make sense that if actually we do proprioceptive rehab, whatever we want to describe that as, that perhaps having task or functional specificity and looking at movement accuracy potentially give us better value than looking at these things perhaps in isolation. We don't currently have any evidence of doing specific retraining of active and passive joint position sense. Mainly this has been looked at patients after surgery, that it has any superior benefit. So it really is an opportunity to reflect and think, what is it we're trying to achieve? And actually, when we look at the fact that all these systems interact, then perhaps that's a better way of applying it in our rehab. So that was a little bit different tonight, guys, but I thought it was an interesting one because I was asked the question. And so I thought, oh, you know what? I'm going to have a look at this in the evidence and see what's out there. And isn't it interesting that there were so many papers about something so simple? So, guys, that was our Facebook Live for tonight. As I say, a slightly different rehab perspective, but I do think it gives us an opportunity to reflect on where we're currently at in terms of proprioception and how using it as a tool, as a term in itself, is probably flawed because it encompasses lots of different things, and the nuances of what's relevant in pathology and what we might want to target rehab wise are probably a little bit more specific. So I hope that was interesting. It certainly got me thinking. I think as ever, there's no magic tool or rehabilitation thing that we can use with our patients. They're all just potential ways of getting a patient on board or giving them a different movement experience. Now, you've been very kind to me tonight. There's no questions there at the moment. Maybe it's a little bit earlier. Kathy, you're very welcome. Just thanks as ever, guys, for joining me tonight. I'm actually on holiday next Monday. I'm escaping to the wilds of Scotland, so there won't be a Facebook Live next Monday. But essentially, the week after, I'll be back, and I've already got some suggestions from people about some things they'd like me to talk about, some quite unusual cases or some challenges rehab-wise. So as ever, don't forget, you can go onto the Facebook page, the public page for Clinical Edge. If you have some key subjects you'd like me to consider, then please put them there. because this is all about sharing the shoulder knowledge, and also giving people plenty to think about. So thanks, guys. I'm loving seeing the comments that it's made people think a little bit. And as I say, as ever, I'll post some links that I think are really useful in terms of just getting us to think a little bit differently and perhaps reflect on what gives us best value in our rehab. So, guys, I'll leave you to the rest of your Monday night. I've got to get ready for my webinar at 7, and I'll very much look forward to seeing you on another Facebook Live back here very, very soon. Thanks for joining. Bye for now.